mode.
Good afternoon, comrades, and thanks for joining today's training presentation entitled Engaging and Retaining Young Adults in Drug Court. This is the second session of a three-part series hosted by Andrew Osborne. Before we get started, I want to review a few housekeeping items to let you know how you can participate in today's web event. I hope everyone's settling in, okay? And we'll get ready to start in a short while. We're now looking at the GoToWebinar interface. To the right of your desktop, which is made up of two parts, the view window on the left, which allows you to view everything your presenter will share with you on his screen, and the control panel at the right side of your screen, which you'll be utilizing for interactive participation. I'll give you a few minutes or a few seconds shortly after I go through the housekeeping so you can get familiarized with the interface. Now let's take a closer look at the control panel. The arrow that you just saw went across the screen is coming from the grab tab on the upper left of the control panel. Here you can open and close the control panel. From the view menu on the control panel, you can choose to auto hide your control panel or totally hide it completely. During the presentation, you have the ability to set up your auto, and you can find that in the auto setup box that has been highlighted. You can raise your hand if you have questions, and we'll try our best to answer your questions at the end of the webinar session. We appreciate you can hold all questions to the very end of the webinar session, where we'll try our best to answer the questions by raising your hand, and we'll try to answer questions as prompt as possible. Okay. Now, without further ado, I'll now turn you over to Andrew Osborne, who will facilitate today's web event.
Welcome everyone to Engaging and Retaining Young Adults in Drug Court. My name is Andrew Osborne and I'm the Director Emeritus of the Training Institute of the National Development and Research Institutes, and as Clyde has mentioned, this is part 2 of a 3-part webinar. This is a collaboration. Not doing it all alone. It's a collaboration between the Bureau of Justice Assistance, affectionately known as BJA. Now, BJA provides a lot of support to drug courts throughout the country. It's also a collaboration with American University, and we'll refer to American University as AU. AU has a ton of repository information, a lot of data on drug courts, and has provided technical assistance to drug courts in the past. And National Development and Research Institutes, affectionately known as NDRI, and what we are, we're a behavioral science research and training organization. As I mentioned last week, this particular webinar is going to take the tone of a review of the literature. It's a turnkey operation. We have limited time, and I want to share with you practitioners where you can go to get answers about working with this particular population. Okay, well, if we're going to have this discussion, we did this last week where we have to have what we commonly call in the trainer business a trainer definition, so that we're all on the same page. When you Google young adults, what very often comes up is the first bullet. The 2 decades between the end of adolescence and the beginning of midlife, approximately 20 to 40 years of age. We can call this the middle passage between adolescence and midlife. But that's too wide and broad a stroke for us to work with. And I know for myself, I've been speaking to...
Okay.
Welcome to GoToWebinar, Web Events Made Easy.
Requested technical assistance from Carolyn Cooper at AU on young adults. And a number of you or your jurisdictions have received training in how to basically design an intervention to work with young adults. Well, we're going to be working with the second bullet definition, 18 to 25-year-old offenders. Those are the ones that we are concerned with. Those are the ones that we'd like to do a much better job with. So, what do we know about that particular population? Many of you practitioners share many things from this list about young adults. They have low education levels. They either drop out of school early or they get pushed through, also known as social promotion. This particular cohort has learning disabilities, which makes them special needs individuals. And again, we need to be set up in our interventions to basically be aware of that. They have low cognitive retention. Again, they don't remember things well. And I mentioned last week to be concerned with literacy, because they are very good at hiding the fact that they can't read. They have a high dropout rate. And when I talk about the dropout rate in this bullet, I'm not talking about school. I'm talking about they have a high dropout rate from diversion programs like probation. Because again, they just cannot meet the needs, and ultimately they violate themselves. They also have a high incidence and prevalence of co-occurring disorders, and we will talk about that a little later on in the webinar. With co-occurring, our definition, they have both a mental health diagnosis and a substance abuse diagnosis simultaneously, which makes it difficult to work with them. Some of them may be involved with drug sales, which may make them ineligible for certain drug courts. Again, problematic. And well, there's chronic unemployment in their environment. They're surrounded, they live in neighborhoods where there's high unemployment rates. People are just doing the street business thing. And we mentioned last week that there's a high percentage of individuals of color that are represented in this 18 to 25-year-old group that, again, we're just not doing that well a job with. We'll explore why that is as we work through the material. Okay, that was last week. This week, we said, you know what? We're going to concentrate on biomedical issues and psychological issues. On the biomedical side, well, here at NDRI, we have been researching the two epidemics since our inception. What are the two epidemics? Drug abuse and HIV. And what we see when we go out and essentially work with treatment providers, work with clients, is a high prevalence in the 18 to 25-year-old group of STIs, sexually transmitted infections, hepatitis, and we've been working with HIV. So again, I would say to you that these are things that are flying underneath the radar. And the last bullet you see there is OBGYN services. I asked last week if any of you were servicing more than 10% of your population as women. Well, many, I believe it was 73% of you indicated yes. More than 10% of our population are women. Well, something that has worked very well for certain courts is getting their ladies connected to the women's clinic. Why? Because so many of the STIs, sexually transmitted infections, are asymptomatic. A young lady may not know that she has this condition until it's very late in the game, very far down the road. For many of these 18 to 25-year-olds, they have not had a checkup, a physical examination since childhood or when it was mandated for school. So it would behoove us, if we're connected to county health services, to connect our 18 to 25-year-olds there, because they may need servicing, they may not have been there in a long time. At this time, I'm going to ask Clyde to launch a poll. And what I'd like to know, essentially, is, do you routinely refer individuals for medical assessments? Do you have that kind of relationship with your county public health services? Because if you do, it would be a feather in your cap. So Clyde, could you launch that poll, please? I believe you folks are answering. And Clyde, I'm not sure what button I should push to be able to see it myself. Okay, we'll get that. We'll get the results of that poll in a second. But what I want to now address and again, the results of the poll. Does your court routinely refer all participants for medical assessments? And I see that the majority of you do. To the tune of 33% indicated yes and 67% indicated no. Everyone does not have the resources available to be able to do that, and I admit that when you have that in place, use it, because again, it can help retain individuals in your drug court. When we look at psychological issues, research suggests that the brain is still maturing during the adolescent years, continuing into the early 20s. And secondly, the brain is not fully formed at puberty, as we had thought in the past, but continues important maturation that is not complete until the age of 24. And that comes from a IMH study. Geed led the team there. And what this tells us is that at the 18 to 25-year-old point, they lack the ability to fully complete multiple objectives at once. They just cannot multitask. The part of the brain that is not fully formed is the prefrontal cortex, which is responsible for this type of work. So you're working with individuals in that 18 to 25-year-old range who are not operating with a full deck. And you wonder why things are so difficult in working with that population. This has a lot to do with that. When we look at, oh, I'm trying to get to the next slide, Clyde. When we looked at the developmental issues that young adults are faced with last week, we pretty much laid these four out: interpersonal relationships, advanced intellectual function, entry-level work/career, and moral and ethical reasoning are the four domains that young adults are charged with. And the work of Erickson and Piaget, they are very clear on what does a child have to do, what does an adolescent have to do, what are their developmental milestones, what do adults have to do. But when we look at young adults and we start to see what are their developmental issues, as the first one that I read, personal relationships, and I mentioned last week, it's not business relationships. It has to be more in-depth. It's not organizational. It has to be more in-depth. So again, something that, some business that they must take care of involving personal relationships, they may struggle with because, again, they just may not have the ability to navigate these particular developmental issues. We have advanced intellectual functioning. Well, adolescents have intellectual functioning, but when we look at young adults, we would hope that they would become more advanced. And I used the example last week of the checkbook. An adolescent can balance a checkbook. That is essentially basic addition and subtraction. But formulating a budget is a higher intellectual function that we would hope a young adult can master. These individuals that we are seeing in drug court are struggling with that because their brain has not matured to a point where they'll be able to essentially complete the task. We talk about entry work and career. Very important because work is so important in our culture. And I used the example of Buffalo Treatment Court last week and basically admiring the work that Judge Russell and Rick Wachowski have done with getting our 18 to 25-year-olds into community college. Because, again, something that is extremely important as far as them meeting their developmental issues. And lastly, we examined moral and ethical reasoning. And we know that baseline, we would like them to essentially attain the reasoning beyond mutual benefit. For many of them, as long as it's okay for me, I benefit and you benefit, then it's morally correct. And again, we'd like them to get past that into some ethical reasoning. And I believe I shared with you last week that educational programs can essentially be very helpful in assuring that the participant does not slide back and regress in their ethical and moral reasoning. Okay, well that was last week. What else should we be concerned about from a psychological point of view about our 18 to 25-year-olds? Well, the changes that are occurring in the brain that result in risk-taking and intensity of emotion. Now, we talked about risk-taking last week, and we said that, in order to develop an interpersonal relationship, you have to take a risk. But the risks that these young people take perhaps are not essentially the types of risks that we would like them to take. So we see risk-taking and intensity of emotion. We see non-compliance. It may be willful. We may think that they're just doing that to piss me off. That's why they're doing that. But there may be something else going on. Judgment is in the domain of the prefrontal cortex, and it's slow to mature for our 18 to 25-year-olds. Drugs hijack the brain. We're trying to get the brain to fully develop. Then the individual is abusing psychoactive substances. That's going to inhibit the brain's ability to essentially complete those tasks. In order to address that issue, it's been suggested that neurodevelopmental education occur. We need to be able to advise our 18 to 25-year-olds of what's going on when they take drugs. What's going on in their brain at this particular point of time, and why is it so important to stay clean? Well, the last bullet you see there is that because we don't have that many evidence-based interventions to work with the young adult population, it's been advised that perhaps we need to blend juvenile and adult-focused interventions. At this point in time, I'd like to launch another poll just to get some information. And the information that I'd like to get is, who are you using as your mental health services providers? Are you using county services, or are you using private providers to essentially get that job done? So take a second and just pick one. Either you're using the county, or you're using private providers, or you're using both. Some of you I know are using both. So again, I'd just like to see the landscape. Essentially, what are you using out there to meet your mental health service needs? Can I see the poll, Clyde, please?
$36, yes. 36 county.
With 36% of you indicate you're using county services. So again, and the balance, I'm going to assume you're using private providers. Okay, that helps. Now, when we say that it's been advised right now that courts use a blend of juvenile and adult-focused interventions, when we look at juvenile interventions, Winters and Breyer have developed some strategies that they are essentially promoting for individuals who are working with this population. So they want to promote activities that capitalize on the strengths of the developing brain. And those activities would be around sports and music. So again, we've been saying for quite some time that perhaps it would be good to use experiential types of interventions. Okay? So sports and music kind of fit in there. We want another strategy that they recommend. They want to assist with challenges that require planning. Now remember, the brain is not fully matured at this particular point in time. When we ask our drug court participants to plan things out, they're going to need assistance. You just can't leave them to do that on their own. So again, we're going to assist them with those challenges. We would like to reinforce the value in getting advice. Basically, we have to say to them, and again, we say it till we're blue in the face, you need help. Okay? It's good to get a heads up on something. You don't want to walk into a wall. You don't want to essentially walk into a situation blind. You'd like to know what to expect ahead of time. We'd like to educate them about risk-taking because they just do not make the connection between risk-taking and negative consequences. So again, very important there. And again, This was developed for adolescents, but again,
Yeah.
the recommendation is that we blend adolescent and adult interventions when working with this middle passage group of 18 to 25. Substance abuse. We need to essentially advise them of the dangers of substance abuse at this particular point in time on their development. So again, another point that we would like to make with them. And lastly, you see there, we would like them to basically tolerate whoops behavior. So you case managers, probation officers, you may not have to come down hard on them all the time. Okay, some things, you cut them a little slack, as my kids used to say. Well, when looking at other interventions that might be of assistance to us in working with this population, the National Institute of Corrections, when looking at community corrections, have listed out what they call effective interventions. And these are effective interventions in reducing recidivism. So you see we have top bullet, assessment and reassessment. One of the goals of working with this particular population is that we would like to make the point of having them engaged in treatment. And if we do this right, it'll lead to comprehensive case management because, again, they have multiple needs, and a case management model seems to work well with this particular group. We'd like to enhance internal motivation. And how do we enhance internal motivation? Well, you know what? We train our staffs in motivational interviewing. Not a bad move. We would like to have interventions targeted. Bottom line, no idle time. When there's idle time, there's going to be trouble. Okay? Skill train. And by skill train, I'm basically talking about cross-training. Everybody needs to be trained. Their skill sets must be enhanced. And then we're talking about the probation officers. We're talking about the providers, both substance abuse and mental health providers. And we would like them to be aware of how best to use those cognitive behavioral models that are out there. And we'll talk about that in a second. We would like to increase positive reinforcement. And by increasing positive reinforcement, I would say, and the literature bears this out, a 4-to-1 ratio. 4 positive for every 1 negative. So think about that from your incentives and sanctions point of view. Okay? So we want to increase positive reinforcement with this particular cohort. We would like them to be engaged in ongoing support in the community. Because remember, drug court, probation are not always going to be around. They're going to have to connect and tie in to what's available in the community. So get them started right now, and we'd be much better off for it. We'd like you to measure relevant practices. You don't want to start a new intervention or a new model without keeping track of what happened. And once you find out what happened, you'd like to provide feedback to your stakeholders. We might be able to improve our intervention as a result. I'd like to share a story with you right now. I was doing a training, I believe, for NDCI, and a young Latino came up to me at the end of the training, and he said, share this story with other practitioners so the same thing doesn't happen to them. And he details to me how he's from Oregon, and they spent a lot of money, a lot of time and effort in developing a new risk assessment instrument. And they thought it was the cat's meow. And they started to use it. Thank goodness someone was keeping track of what happened with the individuals that we were working with.
He's not talking, is he?
Yeah.
Question that probation officers, drug court practitioners would love to know the answer to, because it's going to indicate, is this person at risk to flee? Are they just going to? They want to see that they're rooted in the community. They have family, aunt, uncle, wives, significant others, children in the community that's going to keep them there. And what they discovered was that these individuals were answering no. They did not have significant others in the community because they did not want to draw any attention to their family members who may not have their immigration status up to snuff. So, I love that story, and I love the fact that somebody was keeping track and that they provided feedback. They asked the probation officers who knew these young men from other venues and said, I know that Jose has family members in the community. I was at his house last night. He lives with his aunt and uncle. Why did he answer no? Well, he's trying to protect them, okay, which is normal, okay? Now, what I'd like to do at this particular point in time is one more poll, and I'd like to know, of all those teams out there, have you used or are you using evidence-based interventions? And again, just give me that information, and that would be helpful when I give you information about the resources next week. So again, basically what we'd love to know is, have you used evidence-based interventions? Are you familiar with them? Any of them, whether it's an instrument, a tool, a model, it would be helpful for us to know your experience with them. If you've had experience with them, I should say. Take another second. Okay, Clyde, can I see the results? Okay, I believe we have 30 and 70%. 30% of you indicate yes, you're familiar with.
What is he saying?
What?
What is he saying?
93%.
Evidence-based, but 70% have not yet dived into the pool, so to speak. Oh, just the opposite. Excuse me, correction here. 93% of you indicate that yes, you're familiar with and have used evidence-based interventions, and 7% indicate no. Okay, good information. You guys need to pat yourselves on the back. Okay, now, strategies. Let's continue with some strategies. Screening is something that is mentioned in the literature, and that there are many evidence-based tools out there, and not only from the criminal justice side, but also from the drug treatment side and the mental health side, and these are very short. What a screening is going to do basically is indicate whether or not you need to refer that person on for a full in-depth assessment. And by in-depth assessment, I'm talking about a biopsychosocial assessment. And the question that you need to ask of any assessment instrument, is it normed and validated? And by that I mean, has it been used cross-culturally? Because very often we get assessment instruments that have been used, let's say, on women only or on men only, and then we want to then use it on a heterosexual cohort, and that's just not going to work. So again, is it normed and validated? Is it reliable? And will it assist with a case plan? Because it has to lead us somewhere, okay? So again, that's Those are two strategies there, screening and assessment. How about cultural proficiency? We need to be able to respect the values and culture of the young adults. If we don't do that, we're running uphill. We're just not going to be able to make a connection with them. Case managers. As we continue today, and as we went through material yesterday, it became kind of obvious that case management models are going to be preferred in working with this population because they have many needs. We'll come back to that. We'd like courts to use a strength-based approach. Right, we would love them to ID not only risks, but also resiliency factors. And there's the Search Institute as an instrument, 40 developmental assets that measure both. They identify risk and resiliency. We would like to know the pluses and minuses, all right? The assets and the liabilities of that person sitting in front of us. When we talk about co-occurring disorders in a second, where it's impossible not to talk about the GAIN Center. And GAIN stands for Global Appraisal of Individual Needs. Now, that's the good news. What's the bad news? It's proprietary. It's not in the public domain, which means you're going to have to pay for it. Okay? And supervision, keep in mind that increased supervision may result in increased violations because young adults, they come to us in pre-contemplation. When we remember your stages of change now, they're just in denial completely. Our older folks who are older than 25, well, they reach us in a contemplative phase. They're thinking about it. They're sitting on the fence. Our job is to push them over. But that 18 to 25-year-old, you earn your paycheck working with that particular group. Now, what can help us with this supervision? Again, we're back to motivational interviewing. We have to motivate the individual to want to change. Well, okay. Those are some strategies that we may want to consider. Some of these strategies you may already be using. Well, we've been talking about case managers and case management. It would behoove us just to have a bird's eye view of what do we want, what do we need in a case manager? What's the profile of a case manager? Because we'd like case management to promote treatment engagement. We would like these individuals to be self-aware. We'd like them to identify differences as an issue, and that's all they are differences. We'd like them to accept others. We'd like them to see the client or the probationer as an individual, not as one of the group. Okay? We'd like them to have a willingness to advocate for the probationer. Stand up. Take a stand. And we'd like them to understand culturally specific responses to problems. Because, again, the individual is going to problem solve through their own cultural lens, which might be different from the probation officer or the drug court practitioner who's on the other side of the desk. Okay. We touched on co-occurring. What is it about treatment for co-occurring individuals? Well, there are problems when not taking the medication. And for many individuals that I've had in treatment, they prefer taking street drugs. Why? They feel better. There may be negative side effects with the medication that's being given to them by their therapist. Another point about treatment for co-occurring folks, drugs hijack the brain. They have difficulty remembering. I don't know if this ever happened to you, but I would call an individual in and say, listen, I'd like you to see Dr. Stern up at Columbia Presbyterian Thursday at 2 o'clock. I would write it down, hand it to him, and say, check back with me when you, after you complete your session with Dr. Stern. 5 minutes later, they knock on my door, and what do they ask me? You want me to see Dr. Stern on Thursday, right? Difficulty remembering, okay? They don't recognize consequences of their actions. Again, gets into problems around risk-taking. They have poor judgment. Judgment is the domain of the prefrontal cortex. Disorganization. We ask them to do a number of tasks that essentially require organizational skills that they just don't have at this particular point in time. And to make matters worse, there's a limited attention span, and confrontational tactics just seem not to work with this particular group. So your young adults don't respond well to confrontation types of intervention. So we have to figure something else out. Well, to continue on, and again, this comes from Gaines, the Gaines National Center. Traditional substance abuse treatment is less effective when working with this particular cohort. Why? They have cognitive impairments. They don't work well in confrontational settings, which again, many drug treatment programs employ confrontation. And there's frustration, and they drop out, resulting from abstinence. And again, I've had many individuals come to me and talk about how the marijuana that they're smoking makes them feel better. They're able to complete tasks when they use that drug. That's going to get them into problems in substance abuse treatment modalities. And when we look at the mental health treatment, well, their substance abuse is going to interfere with all of the recommendations that the mental health professionals are making. So the active use of substances is not going to work well in a traditional mental health treatment setting. Okay, well, what are the National Gaines people recommending? Well, they're recommending that that individual have at least 1 year of treatment. Can't do the quick and dirty. Got to roll up the sleeves and give them a year. All right? They have to have extensive assessment, and you might want to add there reassessment. This plays right into the need for case management. The emphasis has to be on psychoeducational approaches. And we have to have high staff-to-offender ratios. And of course, Gaines is recommending we have more mental health professionals working on the team, working with that individual. The more the merrier. I mentioned cross-training of all staff. The POs need to know what are the goals and objectives of the mental health providers, of the substance abuse providers, so that, again, everyone is on the same page. And, as I've mentioned earlier, we would prefer, or the Gaines folks are recommending, it's better to have a supportive approach versus a confrontational approach. Okay. Well, what about supervision? Well, with supervision, which is what we do a lot of in drug court and in probation, let's remember, and I've mentioned this earlier, the 18 to 25-year-olds, they're less motivated to change. Remember, their brain has not matured to the adult level at this particular point in time. They are pre-contemplative, which means they're completely in denial and they're very difficult to work with. Something that you might consider is training, having cross-training for everyone who's working in your court on motivational interviewing. Motivational interviewing is evidence-based. So again, we know when used appropriately, you can make great strides. Increased supervision may produce more violations. The more you look, the more you're going to find. Okay? We might need to take another approach there. And just remember that 4-to-1 ratio. You were like 4 positives to 4 negatives, so to speak. all right, strength-based, all right? So the supervision can take a strength-based approach and not necessarily take a negative approach. Okay, we've been talking about case management. Let's wrap up that particular point on case management. Well, that area of the brain related to reasoning and problem solving is the last to mature. Think about the tasks that we expect individuals to complete while they're in drug court. If they're in that 18 to 25-year-old group, they don't have the horses to run that particular race. Part of their brain that helps organize, plan, and strategize is just not completed yet. So again, they're attempting to complete the task, and again, they just don't have the ability to do that. So what does this require? It requires enhanced and motivational case management services. We need all the help we can get when we are essentially working with this particular group. Okay, that essentially is that overview. And what's going to happen next week, Wednesday, same time, same station, on September 28th at 3 o'clock Eastern Standard Time, I'm going to be listing out and sharing with you resources that you can connect with to find out interventions that work positively with this particular cohort, with this particular group. So that will answer many of the questions that you may have at this particular point in time. And again, we've allotted some time here at the end for some questions. So again, if you have questions, I believe you can type them out. And if I don't have the answer, I will get you that answer next week. Or I will, if I do know the answer, I will share with you where you can get the answer. Because again, I'm being a good health educator here and essentially sharing with you the work that has been done, because we have been talking about the difficulties with this 18 to 25-year-old group for more than 10 years that I can remember. So again, if you have a question now, it might be time to essentially ask that question. As a reminder, when we log off, please don't forget to complete the survey for today's session. I know we had to do a little Gandhi dancing last week, but you got the survey, and thank you for completing that. That is very helpful in planning future webinars.
Question. Stop typing. Stop typing. Send privately. Sounding off, okay. You just did that? I just did that one. And they'll get a list tomorrow. Can I say that? Can I say something? Yeah, you gotta go.
Okay, one more thing. An individual out there asked a question about what would we consider evidence-based, and I responded very quickly, MRT or CYT. CYT is cannabis youth treatment. MRT is motivational and restoration treatment, I believe. But all you have to know is next week you're going to get a list. I'm going to have a list of evidence-based, a list of best practices, a list of what other people are doing, and websites where you can lock in and find more information on that particular topic. And remember, some of these evidence-based interventions are proprietary. You've got to pay for them, and some are in the public domain. And I will essentially share with you which are and which are not. So we'll see you next week. Thank you.
Where is the survey? Why am I